Hi guys, welcome to another interesting video on a very interesting topic. The topic is the Achilles Tendon Rupture. I welcome all of you. I'm Dr. Ankit and welcome to our YouTube channel Human Anatomy by Dr. Ankit. Recently a news came about one of our very favorite cricketer, favorite bowler, Mohammad Shami, who recently was a hero in the recently World Cup. Now he said that he posted on X that he had a successful operation on his Achilles tendon, probably could have been at Achilles tendon rupture, right? So taking this news and the commonality of this topic, let's start this topic. So what is Achilles tendon rupture? Achilles tendon rupture is, you can see in this particular image, this is the Achilles tendon over here, and you can see that this tendon, it goes down and inserts into this bone that is the calcaneus, and this area you can see some inflammation around this area. Just to show you that what was this tendon, let me come to the anatomy part. So now come to the core anatomy part. What actually happens is that in our leg is between the knee and the ankle, we have few muscles. Now muscles in the posterior compartment of the leg, they are known as the calf muscles, right? And the bulk of the leg muscles are those calf. So here you can see the two head of the gastrocnemius muscle, and if you cut the gastrocnemius, what you see the deeper lying soleus muscle. And these two muscles, gastrocnemius and soleus, plus a small plantaris muscle, they go down, they form this huge tendon over here. If you can see over here, this tendon, that tendon is known as the Achilles tendon. That tendon is known as Achilles tendon, which actually inserts down into this calcaneus bone. Calcaneus is one of the tarsal bones. Now it's one of the strongest tendons in the body, and it is formed by one of the largest muscles, you can say. And the major action, the major action of this particular tendon or the muscle will be to do the plantar flexion. So the major action will be what? To do the plantar flexion. Now, suppose this is the foot, this is the plantar flexion. So major action will be plantar flexion. Second thing, do remember also that this gastrocnemius and soleus muscle, the nerve supply of this particular muscle will be the tibial nerve. Just remember, this tendon Achilles forms around 15 centimeter proximal to its insertion into calcaneus bone. And also there is a small muscle known as the plantaris. Coming to the risk factors about the Achilles tendon rupture. Why it happens, to whom it happens, why it is so common. See, normally it is seen that this Achilles tendon rupture is commonly seen in around 30 to 50 years of age, particularly males, and male to female ratio is around 6:1. Now why this age? See, what happens is that when a person is obviously young, 15, 20 years of age, he is in school and college time, fine. They are very active, they are playing the sports and all. Then they go to college, in our mid-20s, early 20s, they leave the college, then they start to do their job or work or business, whatever. So it takes around say 10-15 years for a person to settle down in today's world. And around 35 to 40, around middle age, they start to again, okay, let's do some sports, let's develop our health, focus more on our health, and they start to play some sports and all. Now it is around this middle age, people start to play the games again. Now for 10-15 years, their muscles and tendons were not working that much. So suddenly that that workload again on this calf muscles, it could be one of the reasons of this Achilles tendon rupture, particularly as the males probably they are involved more in the sports playing, so it is probably ratio goes into 6:1. There's also given some fancy names. One of them is weekend warriors. Weekend warriors is that for 5 days a week, people are busy in their job or profile, whatever it is, and weekend, Saturdays and Sundays, they become warriors. Suddenly they are very active physically. Let's do this, let's do that. So it's known as weekend warriors. So weekend warriors, or you can also say that people who are active but intermittently only, right? Not regularly but intermittently active, right? From them also. Now particularly see calf muscles, if you look at your leg between the knee and the ankle, the bulk of the muscles lie in the posterior part, that is known as the calf muscles. Why? Because these are also the anti-gravity muscles. Meaning by what? Meaning by, see, when we walk, when we jog, then this muscle over here, the calf muscle, it gives a push off. You can see in my video on bipedalism, we have told the stages of walking. And do also remember that in this anatomy, what happens is that once these two muscles, they start to form this tendon, no? There is a spiraling. There is a spiraling of around 30 to 150 degrees of this tendon. Now, why the spiraling? It actually helps in storage of energy to give us a push off during walking, as I already told. So this part is very important to understand, right? Spiraling, that's a normal anatomy. So weekend warriors active intermittently, and calf is an anti-gravity muscle. Now, the few sports we have to understand, like in the sports which actually the demand of the game is you have to jump right? You have to move your directions rapidly. For example, let me tell you few sports like say badminton over here, right? Or say basketball over here, right? Badminton, basketball, even sports like cycling. Cycling, yes. Why? See, what happens in cycling is, in cycling, once your foot is on the pedal, your foot is in the dorsiflexion. So most of the times, your calf muscles are stretched. The tendon, this tendon Achilles is stretched most of the times, right? So that is also one thing that you have to keep in mind, that cycling or cyclist people, they are also prone for developing Achilles tendon rupture. Apart from this, let me tell you, there are few drugs whose overdose is said to be related to it. Like for example, some steroids injections or quinolones. Quinolones, we studied in pharma, those fluoroquinolones, ofloxacin, ciprofloxacin, they have some correlation with it. Apart from these drugs, some diseases also is said to be a common risk factor. Now, what diseases are associated? What diseases are associated with Achilles tendon rupture? Let me tell you, like chronic renal failure. Remember that. Apart from this, we have diseases like gout. We have diseases like rheumatoid arthritis, quite common, right? We have diseases like thyroid disorders. We have diseases like of the sugar, the diabetes over here, right? SLE also is common. So these are the few diseases which have shown to have a link with the Achilles tendon rupture. So these were the risk factors. Remember that. Right now, come to the where does this rupture actually happens? This rupture actually happens around 2 to 6 centimeter above the insertion into calcaneus. Remember. So the tendon was being formed around 15 centimeter above the insertion. The rupture normally occurs around 2 to 6 centimeter, and it's a sudden snap. It's a sudden snap, and the person feels very intense pain after Achilles tendon rupture. It's a sudden pain, right? Remember that. So it's a snap and a pain, and normally it is seen more on the left side. Why? Because as 90 or more than 90% of people are right-handed, they normally start running with their left foot. That is a common tendency. So it is said as on the left side it is more common. Now coming to the DD, the differential diagnosis, see, there can be many things. But remember, the more common ones over here would be a bursitis. Why bursitis? Obviously, as the tendon is going into calcaneus, we have a bursa over there, right? Where bursa is what? To decrease the friction between the tendon and the bone. So it is good bursitis, could be some bony problems around it. Now there are two other things, peritendinitis and tendinosis. What actually happens is, because as the tendon is going to insert into the bone, around the tendon there are paratendons or paratendon sheath over here which might get inflamed. It is not actually the tendinitis, the inflammation of the tendon. It is the inflammation of the tissues around the tendon. That is, it is known as paratendinitis. Second thing is tendinosis, small nodule type feeling. If you carefully palpate, now that is one of the parts of the examination in a patient of this Achilles tendon rupture. If you carefully palpate the entire calf muscle, the gastrocnemius and soleus, you might feel small nodules in around the tendon. That is known as tendinosis. Now coming to the investigation, obviously, what investigation? So what will happen is the patient will come to you with obviously pain. You will ask the history, what happened. He might normally explain you that suddenly I was playing this, suddenly this happened. I was just trying to jog, starting to jog, or middle of a jog, whatever it is. What are the various tests? Test meaning by the tests which you do on a physical examination. Why? One over here is a hyperdorsiflexion sign, and one over here is a Thompson test, common ones which are done. Now what is this hyperdorsiflexion sign? Let us see this first of all. In this particular test, what you do is you ask the patient, this suppose is the bad, to lie prone. So patient will be lying prone, head and over here, the neck, the trunk and the thigh over here. And then when the patient is lying prone, you ask the patient to flex the knee, So patient will flex the knee 90 degrees. So knee flexion, the knee flexion is by 90 degrees. Then you look at the foot of the patient. This is the red color, say foot of the patient. What is hyperdorsiflexion? Now suppose this one over here, which I am putting this green star, is the one which is actually having the Achilles tendon rupture. Now in this particular foot, there will be more of a dorsiflexion. Dorsiflexion is movement in this direction, right? So that is hyperdorsiflexion sign. More dorsiflexion, that is suggestive of Achilles tendon rupture on that side. What is this Thompson test? Thompson test is nothing but you just simply have to squeeze the calf muscle, right? In a patient lying prone only. Patient is lying prone, right? Knees are not flexed, simple. You squeeze the calf muscle in a patient lying prone. When you do it on a normal patient or on the normal limb, you see some degree of plantar flexion, because obviously these muscles, when you squeeze the muscle, the tendon will be stimulated, it will move or it will plantar flex the foot. Normally you see this. If you don't see a plantar flexion even after squeezing the calf, it could be a sign of an Achilles tendon rupture. So remember these two physical examination tests that can be easily done. This is common sense, right? So both are done in the prone position. In one, you have to flex the knee to 90 degrees to look for dorsiflexion of the foot. In other, you just to squeeze the calf muscle to see any plantar flexion or not. The investigations also. What investigations do you think? Obviously, we'll go with the CBC, complete blood count, just to rule out other stuff. That's it. We can even go with the X-rays just to rule out any bony problems or not. Right? Then we can go for the ultrasounds or the MRIs. Obviously, MRIs obviously would be more confirmative, but this is more of a clinical diagnosis than being depending on some investigations. Right, ultrasound and all just to rule out. MRI just to tell what is the degree of rupture, how far are the this torn ends of the tendon, so that might be helpful in obviously the surgery if they're planning to. A normal treatment of this surgery, though people go to conservative treatment as well, we'll see it later on. Mainly over here you have to focus on the MRI, ultrasound, X-rays and CBC just to rule out other conditions. Right, as I already told you, the diseases over which can be associated in the risk factors. So the diseases as we have discussed over here, see for that obviously you have to do some investigations like CRF and gout and RA. For CRF obviously you do a KFT, others gout, you do uric acid. For RA you do like RA factor, you do NT-CCP or other test over here. Thyroid obviously, TSH, sugar, HbA1c and SLE. For that you have to do some blood investigations just to rule out other conditions are associated with it or not. So investigations obviously has to be taken up under the care of a doctor, qualified doctor, normally a orthopedician or someone associated with that, right? So obviously for the full guidance only we have to go forward. So the management of this, Achilles tendon rupture would be what? Management is obviously first of all is rest. Obviously there's some tissues, there's obviously some severe soft tissue injury, even if it is partial tear. You have to do some rest, you do pain control. How? Obviously NSAIDs. It's not controlling, then go with opioids, go with other drugs, you do some pain control obviously. Then for people who are not going for the surgery, there could be conservative treatment also, or even you have to buy some time, you do a serial casting and finally some rehabilitation has to be done. This is a basic management, or you can say this is sort of, we can say a conservative management in this particular Achilles tendon. So now come to the fine picture, what to do. Come to fine part, the doctor will obviously ask, okay, what have you decided? Let's go for surgery or not? Or this is your call, or it could be doctor's call. See, surgery can be open or percutaneous, fine, or there could be a conservative management as well. Now, obviously, if the person is inactive, very old age, inactive person, so in those cases, the doctor might opt that, okay, better go for a conservative management. Or if the patient is not convinced that I don't want to do a surgery, obviously then we have to go for conservative. But normally most of people go with the surgical treatment, which is either open or percutaneous. Well, the studies have told us that there is a risk of re-rupture. Meaning by what? Meaning by if a patient goes with the surgery, there is a risk of re-rupture of only 0 to 5%. But in the case of conservative management, there is a risk of a re-rupture of 40%. So obviously people normally, if they're active, even they are slightly active, people normally go with a surgical treatment, right? Because the risk of re-rupture is obviously very less, right? So remember, that was the whole management and the whole anatomical part of the Achilles tendon. Just a small addition over here. Now there's an image showing us few things. The skin and the fascia has been removed. This over here, this is the tendon over here, the Achilles tendon or the tendocalcaneus, whatever you want to call it as. Well, there are various types of surgery obviously. Surgery, you have to open up the skin fascia, you have to either take some part from the gastrocnemius muscle, or you can use a plantaris muscle because that is used as a graft. But the common question is, while doing a surgery for Achilles tendon rupture, which nerve can be damaged? Which nerve? Now that can be a very good MCQ for your other exams if you are giving any exams, medical related exams or PG exams. There can be options like sural nerve, there can be options like saphenous nerve. If I only give you two options, which option would you think about? Right? You can either answer in the comment box as well. Though I will tell you it is this nerve, but think what, which nerve is this? Which nerve is this? This is the lateral side, that is the medial side, this nerve. This is your sural nerve. So it is normally the sural nerve that can be damaged. But this is a cutaneous nerve, so it is close to the skin part. And this vein over here is actually the short saphenous vein. But the saphenous nerve actually is on the medial aspect and more anteriorly. So that was all about the Achilles tendon rupture topic. Let me just give you a quick revision of it. So first of all, okay, that was recent news, but okay, that is also important news, particularly for cricket fans. Achilles tendon shown over here, inflamed over here. Anatomy, remember, you start with anatomy obviously. Risk factors I told you, middle-aged men who are active intermittently. So always go slow, start slow and then you gain some speed. Then obviously some drugs are associated with it, and some diseases are also. So this is one medical perspective, so remember that, right? Then location, I told you, location around that. And then DD, obviously I told you, peritonitis and tendinosis, these are two things which you need to remember. Investigations and examination are very basic, logical, hyperdorsiflexion and Thompson test, so do remember that part as well. Management is obviously start with conservative, then obviously move to surgery, and you have to take your call, or the patient has to take their call whether to go under the knife or not, right? And then remember, this could be a question of HNR. So that's all from my side. Hope you enjoyed. Don't forget to press the like button and do comment if any other topic you wish to be discussed. That's all from my side. Bye bye. Take care.